A chemical flare ignites deep inside the chest, a relentless, chronic sensation, often mistaken for simple temporary heartburn. This occurs when stomach acid escapes its designated chamber and travels upward into the esophagus, an event medically defined as gastroesophageal reflux, or GERD. While many experience this occasionally, approximately 20% of the United States population faces this acid breach on a daily basis. When these instances become regular and long-term, the condition is reclassified as Gastroesophageal Reflux Disease, GERD. At this stage, the reflux is no longer a fleeting anomaly. It is a persistent medical state that requires targeted intervention to prevent lasting damage to the esophageal lining. Food travels down the esophagus to the stomach, a chamber holding caustic juices. Guarding it is the lower esophageal sphincter, LES. This muscular ring acts as a vault door, relaxing to admit food, then snapping closed to withstand surging acid and protect the delicate esophagus. However, this seal can be weakened by physical pressure. Conditions like obesity or pregnancy increase abdominal pressure, forcing the valve to struggle against the weight. Chemical triggers also compromise the valve's integrity. Factors like smoking, consuming strong alcohol, and eating fatty foods cause the LES muscle to relax prematurely, breaking the seal when it should remain tight. Gravity and anatomy play final roles. A hiatal hernia can distort the valve's position, while lying down after a meal allows stomach contents to press directly against the compromised opening. When these pressures overwhelm the LES, the body's primary blast door fails, leaving the upper digestive tract completely defenseless. The result is a violent breach. Harsh stomach acids and digestive enzymes surge aggressively upward into the unprotected esophagus. This immediate contact causes sharp chest pain and regurgitation, often leaving a bitter or sour taste in the mouth. If the acid reaches the upper throat, it can trigger respiratory symptoms, including a chronic cough, wheezing, and morning hoarseness. Over time, the repeated chemical burning of the esophageal wall can lead to a severe complication known as Barrett's esophagus. In this state, the esophageal lining permanently changes its cellular structure to cope with the acid. This significantly increases the risk of developing esophageal cancer. What began as a simple valve failure becomes an escalating chemical injury, making early intervention the only way to stop irreversible structural damage. The first line of defense reduces physical pressure on the valve, using gravity to keep acid contained. Behavioral changes, such as elevating the head of the bed by 6 inches and finishing meals several hours before sleep, provide a constant downward pull on stomach fluids. For immediate relief, over-the-counter antacids act as chemical buffers, neutralizing the acidity of the liquid already present in the stomach. To address the problem more aggressively, doctors prescribe proton pump inhibitors, or PPIs, to stop acid production at the cellular level. These molecules attach directly to the acid-producing pumps in the stomach lining, forcing a shutdown that drastically lowers the overall acidity. While these chemical and behavioral workarounds manage the symptoms effectively, they do not address the underlying mechanical failure of the LES itself. For patients who don't respond to medication, the remaining option is to physically reinforce the failing valve. This is achieved through a surgical procedure called fundoplication. The upper portion of the stomach tissue is stretched and wrapped entirely around the base of the esophagus. This creates a structural collar that restores the seal, preventing stomach contents from breaching the valve. Through chemical or physical intervention, the internal fire of GERD can be extinguished, allowing the body to heal and reclaim its natural defenses.